started on our keynote speak. Please have a seat. We're just awed at the live stream. It actually has our slides, and it's all Greg's the magician over there. So just really quickly, this is the Wordle that came up from a lot of the commentary from our discussion in the session earlier. You can sort of see some of the key themes coming out, a lot of positive in community and care. So really just a nice, and thank you to Deb for putting that together, despite the fact that her computer crashed halfway through and we've had a little, anyways. So we go on. So it is now our pleasure to introduce our guest speaker for today. And just before I do the formal long introduction, Nancy's going to say a few words.
Thanks, Joanne. So this past September, it was my great pleasure to represent collaborative practice at the Altogether Better Health Conference 9 in Auckland, New Zealand. The overarching theme of the conference, Transforming the Landscape of Healthcare, brought forth presenters from a range of backgrounds to share and explore learnings from Maori, Pacific, and Indigenous peoples around the world, to the central role of clients as part of the interprofessional team, to the specifics of interprofessional care, also the social, political, economic, and cultural influences on interprofessional working, and of course, research and evaluation approaches and outcomes. I suspect that many attending this significant event found Dr. Gilbert's keynote presentation to be a highlight. I certainly did. His address, Leadership, Interprofessional Transformation, Are We Making a Difference? Conjectures and Refutations, challenged us to consider whether the transformation in interprofessional practice, care and education through structures, processes and change have in fact led to more learning together, to improve safety, and to improve quality of care. His perspective on forms of collaboration, where, how, and when it is happening, sometimes under our very noses without us truly recognizing it, was reassuring, motivating, and inspiring. I anticipated that our time with Dr. Gilbert today will do much the same.
Thank you, Nancy. So it was Nancy's introduction to Dr. Gilbert in New Zealand that actually led to us inviting him to come and join us today. So now I have the distinct pleasure of formally welcoming Dr. Gilbert to Holm-Bloor View. And as Nancy has alluded, Dr. Gilbert is sought after and internationally renowned in the field of interprofessional education and practice. And just before we began, he was talking about the 4 or 5 different countries he's visited just in the last 3 or 4 weeks. So we're really lucky to have him come to speak with us today, and we feel like it's a bit of a coup that he'll come to Holm-Bloor View to talk to us. Dr. Gilbert has been a seminal leader in the education of health professions, both in British Columbia, across Canada, and internationally. His vision and leadership led to the concept of interprofessional education being developed as a central tenet of collaborative, person-centered practice and care. Dr. Gilbert is the founding principal and professor emeritus, College of Health Disciplines, University of British Columbia. He's a senior scholar, World Health Organization, Collaborating Center on Health Workforce Planning and Research at Dalhousie University, and adjunct professor, Faculty of Graduate Studies at Dalhousie. He holds the Dr. T.M.A. Pai Endowment Chair in Interprofessional Education and Practice at Manipal Academy of Higher Education in India, and he's an adjunct professor at the University of Technology in Sydney, Australia, a man of many jobs. He is founding chair, the Canadian Interprofessional Health Collaborative, which we've talked about this morning, and he was previously adjunct professor at the University of Pittsburgh and at the National University of Malaysia. He was co-chair of the World Health Organization Study Group on Interprofessional Education and Collaborative Practice. He was elected a Fellow, Canadian Academy of Health Sciences in 2008. He was awarded the Queen's Diamond Jubilee Medal in April of 2012, and in October of 2013 received the Outstanding Lifetime Contribution to International Allied Health Development Award from the International Chief Health Professions Officers Organization. Perhaps most notably, Dr. Gilbert was appointed a member of the Order of Canada in 2011, Canada's highest civilian award. He has also received the degree Doctor of Laws honoris causa from Dalhousie University in June 2016, and he was the recipient of the Pioneer Award from the National Center for Interprofessional Practice and Education in 2017 for his groundbreaking work in advancing the field of interprofessional practice and education. We are so delighted that Dr. Gilbert is able to bring his wisdom, his expertise, and his passion for interprofessional practice and care to Holland Bloorview. So without further ado, I'd like to welcome him to the stage.
This side? Okay. All right. I would just like to acknowledge the Indigenous peoples on whose territory I am talking this morning. Well, good morning, and it's a pleasure to be back at Holland Bloorview. I was here in 2010 when we were extremely excited about the World Health Organization report, which I was happy to see up today. And of course, since that time, we've also worked on the way in which we might put things together so that we had a set of competencies that really do represent the interprofessional education. So it's great to be here. And you needn't complain about the weather. I've been in Toronto many occasions when it was a lot worse than it is today or yesterday. So please don't apologize for it. I was saying I was going through here to Zurich about 3 weeks ago. It was the night that you had the worst snow in 40 years in Toronto. So, okay, is this going to go? Or is it going to go on here? Oh, it's okay, we'll do it here. Yep, there. Okay, I have to decide which of my pair of glasses I'm going to need, so forgive me. I actually sat on my other glasses and I'm waiting for my new ones to come. So, I'm going to tell you things this morning, which, yes, it is still this morning. I'm going to tell you things you already know. So, you'll say, well, we know that already. But, knowing something already is not the same as putting it into a different kind of frame. So what I'm going to try to do is to help us think about that frame in which those things we're trying to fit. I'm going to do it also by looking at all of the kind of topics we've been tackling for the last, at least in my life, 40 years with respect to interprofessional education. That's the what was. And those topics which still actually are topics we are tackling. So that's the what is. And I will bet a nickel to a dime that they will still be tackled next year and in 10 years' time. That's the shall be. And the reason for this particular continuum is because they are incredibly complex. Learning together to work together is a dream that we have. And it was lovely to sit back in the corner, quietly making notes as you were reporting this morning, thinking about the way in which an organization like yours is able to do things that really are not possible in the acute setting, and in which we also have terrific problems when we go on the street and work in mental health. I heard a lot of words and I thought, that's a good word. Where's that going to be down the pike when we start to measure it? So I'm going to talk something about measure, because I am very interested in 5 years' time, not just today. Oh, John, remember, you've got to do it here. So, collaborative practice. So if you ask people, do you want change? They all put up their hands. Yeah, we want change. It'd be great to have change. And of course, that's what you've been doing. I'm really impressed with what I've been reading. I've read around the walls. But then you say, who wants to change? It's really difficult, right? I mean, we're comfortable where we are. We've been doing things the right way. At least we think they're the right way for a long time. And, you don't have to put in a new office. I really like this place. Very simple things where change could be easily done, but which we resist. And it's been very difficult in the life of the healthcare professions and social care professions to face what is necessary to make those changes. Very difficult because, as you all know, the silos are enormous. So I went through No Boundaries. We had a wonderful conversation a couple of months ago about what no boundaries meant here. And I was looking for interprofessional themes. So, I found them. Page 9, page 10, page 11, page 18. If you look at what you have written, because I understand that this was a very community-oriented kind of talk about where things should go, you can see, integrated approach to research, teaching, and care, knowledge development, interprofessional teams. So it's not as though you haven't been thinking about these things, you clearly have, but those themes really don't have boundaries, which is why I really like the title that you put on the report. But here's the issue. Wherever I go and whenever I meet with some kind of commissioner or another, and whenever I am with pointy-headed academics who come from biochemistry or some other obscene academic environment, they'll say, well, does it make any difference? So this is a kind of null hypothesis I engineered. Now, don't worry, we're not going to do any statistics today, but you probably do remember from your very elementary statistics course the null hypothesis. There is no difference. So what people are asking all the time is there any difference if we kind of go through all of this hoopla that you want me to go through in order that we learn together, et cetera, et cetera, et cetera. And what we're seeing is that there are differences. And in fact, I only have to listen to you talking this morning to kind of feel the difference. I can't know it because I'm not here, but I can feel it as you're talking about what that difference is that is made when people actually do start talking to each other. Now, just to be clear, when I talk about interprofessional education, I am talking about a continuum, right? It's interprofessional education, interprofessional learning, interprofessional practice, interprofessional care. So I just hyphenate it to IPE. But I really am talking about this continuum, from classroom to practice and then out again. And when we think about interprofessional education, we have to think about this wonderful collaborative team who are doing it all for you and working with you. And because the onus is going to be on them and their partners in the other team, the teaching learning team, to kind of get a fix on this. So interprofessional collaborative practice. Oh, I'm sorry, it looks like my line slipped. This is not very clear. It's the collaborative care model from Nova Scotia. And I'd been looking for a long time for something into which I could fit the elements of learning with, from, and about each other for the purposes of collaboration to improve quality of care. And remembering the wonderful work of Donna Bedian, who said, structure, process, outcome, these are the measures that we ultimately need if we want to look at the goodness of a facility. And I think that Nova Scotia did a pretty good job. So you can, in fact, see people, process, information, technology, and then strong and effective communication, committed and supportive leadership, and the other two on the other side, which I can't see from here. But what we're trying to do has to ultimately fit into a care model, right? So that's really what you're talking about here. What is that collaborative care model? And when we do that, we want to look at these parts. And in fact, you've named them this morning in different ways. You've been naming people, process, information, technology. They kind of were woven through the stories in a very nice way. But as we look at those things, and what Nova Scotia is discovering is, it's all very well to say, process, integrate evidence into practice, streamline processes, empower patients and families, blah, 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 if you don't measure. We have lots of stuff from lots and lots of reports around the healthcare systems all across the world, which are full of words. And then you say, so tell me downstream, how did you measure all those words that you put up? And one of the problems with our competency model, and it is because I remember when I sat down with the group first and said, we've got to work on this. And one of the problems is the wording, okay? Because we have to be sure that the words are testable. They have to be testable because otherwise, how are you going to say it's of any value whatsoever? Okay. But let me just say a quick word about definitions. Interdisciplinary is not interprofessional. Multi-professional is not interprofessional. And transdisciplinary is not interprofessional. And it reminds me of that wonderful quotation from Humpty Dumpty. So he says, when I use the word, Humpty Dumpty said in a rather scornful tone, it means just what I choose it to mean, neither more nor less. The question is, said Alice, whether you can make words mean so many different things. The question is, said Humpty Dumpty, which is to be master, that's all. And the resemblance to somebody who's well known to you illustrates the point, right? Yeah. So we have to be careful about the definition. And the definition that we use is from the Centre for the Advancement of Interprofessional Education in England, which was developed over about a 12-year period by a group of nurses, social workers, physicians. I think there were physiotherapists in that group. I know there were 2 other groups that were there. And it took a lot of time to get to this definition because at the end of the day, you want it to be testable. If you're going to make it up, it's like the table of elements. If you want to do chemistry, we wouldn't do it today without table of elements. If you want to do interprofessional education for person-centered collaborative practice and care, we've got to have a testable definition. And interestingly, so I was, of course, listening to the stories and thinking, I wonder what they thought about the learning with, from, and about as you were working through the stories. And clearly you were, but it wasn't coming out in the words that I would say, I can test that. But they're there, all right? But we're still not quite sure about how to put this part of the definition into the curriculum, okay? So I'm going to talk about that in just a moment. Now, people, when they talk IPE, completely forget that there are 2 parts more to the definition. So the reason that we want people to learn with, from, and about each other is because when we have looked at collaboration and collaborative practice in the past, it was very clear that the reason that it didn't go was because people were trying to collaborate without knowing who they were collaborating with. Well, I work with a physiotherapist, and I work with a whatever, and I work with a whatever, and I work with a whatever, and you say, so tell me about those people. Well, no, I work with those people, so tell me. No. So the second part is really, really important, right? If we haven't done the learning with, from, and about, how can you do the collaboration? I see this all the time. I can go to terrible acute care hospitals. And I won't name any of them, but I can go to, and honestly, they don't get it. They still don't understand why collaboration doesn't improve. And I only have to look around the walls and read the stuff that's being done here to see collaboration in practice. Now, that doesn't tell me whether the with, from, and about piece is in those things that are about collaboration. It's there, but I'm not quite sure where. And above all, the reason for doing this is because to err is human. The great report from the Institute of Medicine, which finally made us fess up that people die unnecessarily because healthcare professionals, social care professionals, don't know how to collaborate properly. And we have a Canadian study on adverse events. We don't call them medical errors anymore, which is perfectly appropriate. We call them adverse events. And we all know about adverse events. So the quality of care and services is about preventing those things from happening that have killed many people unnecessarily. Okay, so this is a very, 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 very important definition to understand. the components of it. And the Center for the Advancement of Professional Education made a slight change to the definition the year before last, because what we were discovering as we were doing research was that you can't just focus on students. You had to also focus on everybody in practice. So they added members or students of 2 or more professions. Because what we want to look at is you, right? Not just the students who come here. And then what we realized was the quality of care is also very reliant on services. And so when we looked at adverse events or near misses, what we discovered was that they occurred because there was something wrong with the service. Now, service could, we'd have to spend some time talking about what that meant. So the definition now includes members and services because that came out of a lot of work where we recognized the adverse events occurred because of something that happened in the service, all right? Now, here's a conundrum that has to do with those prepositions with, from, and about. So when we're in a group, and we're trying to prepare a really good practice, clinical practice, that provides the best care, I need to know what I know. Now you might say, that's obvious. Of course I know what I know. Oh yeah? I did a little study at UBC and I asked a bunch of nurses and a bunch of social workers and a bunch of physios, what are you? And that was the question, what are you? Honestly, they couldn't tell me. Not in a way that made sense. Well, I'm a physiotherapist, yes, but what are you? So I need to know what I know is very, very important if you're going to go into this interrelationship, all right? And even more important is I need to know what you know. And I love the descriptions of the professions up on the wall there. However, that doesn't mean that I know what you know. I know who you are and what you do, but I don't necessarily know what you know, okay? So another little issue that we're trying to get our hands around. And then you need to know what you know. Like I need to know what I know, you need to know what you know. And it's not always clear that that is in fact the fact in team-based collaborations. And then we need to know what we know. And that's much more difficult. When you get into a complex area of care, we need to know what we know, makes excursions into all kinds of areas that are possibly not those things we thought about that we actually know, and which actually can be reflected as we think about the problem that we're working on. But above all, we need to know when we need to know. So a very legitimate claim is made that you don't always need a team, right? And it's true. When I go to see my family doc, I say, Max, how many runny noses did you see today? And he'll say, well, lots of runny noses. Runny noses are the way in which physicians make money. But he doesn't need a team for that. So we need to know when we need to know. And that we haven't got our hands around fully yet. And again, it's interesting, I was reading the ones on the other side, because I haven't completely read these. Reading those, thinking about this issue. We need to know when we need to know. And it's very nicely illustrated. Now, Dan Way and Linda Jones and Nick Busing, who are your colleagues, were your colleagues here in Ontario, wrote this brilliant paper for the College of Physicians back in whenever it was, 2000. And we were talking then about what is IPE really? And we wanted a description, not necessarily a definition, we want a description of what that was. And we have a description in the WHO report, which we kind of built around this. But I think that when you are thinking about what it was you were doing this morning, it is a process, you know, this IPE stuff. It's a process for communication and decision making. You just think about when you were talking about how you were communicating, right? And it's very clear. I mean, what is it that was up on the board, and then how were you communicating when you were talking about it? And then what made the clarity of that communication really, really important was because you want to make the right decision. You want to arrive at the right decision. So communication has to be clear, because in order to arrive at that right decision, then you've got to enable the separate knowledge of each of us, the shared knowledge that we're trying to put together around the table, and then the skills that we have, knowledge, you know, et cetera, skills, and the skills that we have that allow us to work synergistically, you know, to do this and not this. I had a graduate student at Simon Fraser who was in communication and did a really wonderful dissertation on shift change. And shift change is, of course, and this was shift change at the end of the night shift. And very interesting how the knowledge and skills of all of those people who had just come off the shift were not changing attitudes and behavior. Everybody was talking like this, you know, well, we saw Mr. X and Mrs. Y and whatever, go through the list. One person says their piece, the next person says their piece, the next person's already on their BlackBerry, the next person says their piece. Complete blank, okay? So this process is for communication and decision making. Think about that. And communication is absolutely critical. I'm going to say a word more about that in a moment. So think about IPE as a process for communicating and decision making. Now that presents us with problems about curricula when we bring students into this agency to learn what it is that you wish to teach them, right? Because I'm sure you're brilliant at doing this, but I could take you into a couple of places in Vancouver where the students come in one by one, by one, by one. It's the diabetes clinic. That's just one. And they go through like this. And they get like a month in the diabetes clinic, right? So we have pharmacy, social work, nursing, medicine, students going like this. And nobody's said, wouldn't it be better if we actually went through like this? And the reason that they haven't is because the curriculum is set up to do this. It's not set up to do this. Why? Because professions have said, in order to get your piece of paper to graduate, you'd better know this and this and this and this and this, and your preceptor, mentor, whatever the name of the person is that's in the clinical facility is the person who's going to teach you those things. Because we've never taught them about the inter. So it's not surprising. So this is where we're trying to go with developing the curricula. So the questions then for us are, and we call them WH questions, who develops the interprofessional practice curricula? Is it you? You know, who develops it? And that's really, really important. I mean, does it get developed over on the other side of the building by the teaching and learning folks? Or are you guys going to be really engaged in doing that? And then how do you align that interprofessional curricula with practice in your various areas here? The ones that I see, you know, on the posters. And then where can you align that curricula, that interprofessional practice curricula? Because clearly there are going to be places where you can't align it because you're very busy teaching the students about the things they need to learn in order to be a physio, a OT, et cetera, et cetera. But got to think about it. And then when can you initiate that curricula? Because you can't do it the moment the students come in here. They're not coming here expecting that. You know, they're coming here to learn how to be whatever it is that profession is that they happen to be in. So those are really tough questions for practice agencies to think about if you want to really engage the interprofessional piece. And I can't tell you that I have, you know, an answer to each of the WH questions. We have data, we have kind of things to do, but they are really, really important to get the bedrock down so that you can then do. And what we've come to realize is that interprofessional curricula have to be an integral part of the practice culture, okay? So you can't, it's very hard to come into a place where, I mean, it's wonderful to come in here, honestly, and I'm not just saying that because I see it all the way around the room, but it's very hard to go into a place where IP is not an integral part of the curricula, where people say, well, what's that? Or we don't do that. It has to be the lived experience of students and practitioners. So, you know, that's why I say they can't come in immediately and start this, because you've got to introduce them to that kind of, you know, experience. And it has to be part of your experience, you know, as practitioners. You have to have lived that interprofessional piece in order to be able to teach it. And then when you do it, everybody has to agree. Now, again, you might say, but John, doesn't everybody agree? No. I go to lots of places where people say, we don't do that. That's not us. You know. It's no wonder, you know, we take students and they go in and they say, but they wouldn't let us do it there. So it has to be understood, has to be agreed, has to be up there in the mission and vision of Holland Bloorview. Interprofessional, practice, education, etc. And most important, it has to be built on the definition and the competencies. And I go to lots of places where people say, well, we're doing it. And I say, well, tell me how you're doing it. And then they will reel off, you know, getting together, et cetera, et cetera. Say, well, do you use the definition? And they say, well, we use interprofessional education. I say, yeah, but you use the definition. No. So you've got to be sure that when you put in this curriculum, you're working with the definition and you're working with the competencies as they are at the present time, recognizing that it's unlikely that the definition is going to change, but we will get a better feel of the competencies because they're very languagey at the moment. You know, some of them are testable, some of them are not testable, or they are quasi-testable. And I take responsibility for that. We just wanted to get them out, and it's amazing, you know, how often they're used. But you have to build it on the definition. You have to. Why? Because go back to that null hypothesis. If I want to be able to say to the world, you know, what I saw at Holland Bloorview measures against what you're doing here in XYZ, A, B, and C, it can only be done if I'm using those things. Because otherwise it's all apples, oranges, pears, and bananas. I've got to be able to say they're doing it this way using this definition, and we're measuring the same kind of thing. So here are some curricular essentials. The definition, and then use assessment and evaluation tools to measure cross-sectionally and longitudinally. I know, because I know what Catherine does, I know that you have cross-sectional data. And cross-sectional data is very useful. You know, you do it at this time, you get a snapshot, you get a sense, okay, we can work from this. But in order to affect system change, you need longitudinal data, which is the hardest to get. In any field, it's hard to get. But we have to have it. So if you're using the definition and you're using the competencies, and we know you're going to be here for a long time, because you've already been here a long time, then there is this possibility of collecting this longitudinal data which answers the null hypothesis. It does make a difference, particularly since we're now kind of looking at oranges and oranges and apples and apples. And then always have a research strategy going, you know, the research strategy that represents the definition, the competency framework, and the scopes of practice. Now, scopes, as we all know, is a big pain, right? The Canadian Academy of Health Sciences wrote a very good report on scopes, published about 3 years ago. It doesn't answer all of the difficulties, but it certainly puts a boot to some of the silly stuff we do around scopes of practice. I remember when we were doing scopes for nurse practitioners in British Columbia and the College of Nursing, it wasn't called the college then, it was the association asked me if I'd go and help them with it. The scopes were this thick. You say, how the heck can anybody do all of that, you know? And then you look at it and you say, but that's what a social worker does. Actually, that's what the physio does. Actually, and the scopes got narrower and narrower, okay? But scopes you have to look at as we set up the research strategy, because you want to be sure that somebody's nose is not going to be out of joint because somehow or another, you know, you've chosen their favorite scope of practice to interfere with. But you have to have a research strategy that is like, and that I think, when I think back to the beginnings of our rehab centers in Vancouver, the Pearson Adult Rehab Center, and then Sunny Hill Hospital, which for those of you who know Sunny Hill is just about to move to Children's Hospital. They got, again, a huge new wonderful building, et cetera, et cetera. But I remember that when I first visited both those places, there was no research program in place at all. People didn't do research. We're a service entity, you know, we just do service, we don't do research. And you say, yeah, you know what, but if you want to make an impression on those guys who actually move the money around up there in something called the provincial government's Ministry of Health, you better have data. Because data tells a story. See, the stories are wonderful. And I used to go to, well, in fact, I already still go to the minister, say, you know, I have this story. And the minister loves the story, right? Even Mr. Ford might love some of your stories, but I mean, the minister usually loves a story, but then the deputy says, okay, so where's the data? So stories are great, but data is greater. So I'm glad you've got a copy of this because it's not very distinct. Well, it's okay. Now, we did this in 2010, and we've been working on it for about 3 years before that. And it took a lot of grinding, honestly. It just took a lot of grinding. But when we looked at, you know, CanMeds and other kinds of competency frameworks, we figured that we got our fingers on things that could be seen as interprofessional, right? Because every profession has a competency framework, you know, the things that you're supposed to be able to do in order to tick the box in order to get your credential at the end of the day. Role, clarification, team functioning, interprofessional conflict resolution, collaborative leadership. You have to think carefully about where those things really do become interprofessional, which is what we tried to do in the small print, all right? And important when we think about the competency framework to say it is nested like a Venn diagram in other determinants of health. You know, so clean air, clean water, et cetera, et cetera, et cetera. Somewhere out there in the community, on the periphery of our competency framework, are things that actually do have an impact on whether or not we're able to do these things. Just think about it. So I just took the central notion, interprofessional collaboration, the four elements, the four big elements that are around the side, and I put up their communication. Now, for 7 years, I sat on the BC Patient Quality Review Council. It was set up by the minister. There's an Act of Health. There were 7 of us on the board, and our job was to adjudicate the worst complaints that came out of the BC system. And the BC system gets about 80,000 complaints every year about healthcare. which is, I mean, it's probably the same percentage number here in Ontario. And it's all the way from why is food so dreadful in a hospital, you know, to why was it that my mother, who was perfectly fit when she went into hospital but had just broken her leg, died in 3 weeks and nobody talked to us about it. So when you look at the complaint system, and when we look at the patient kind of satisfaction surveys in our system, about, I would say 83–84% of the population is happy with, 83–84% of the healthcare system. They're happy that, get me in, get me well, get me out seems to work most of the time. But it's the ones where it doesn't work that give us an insight into what it is that's causing the problems in the system. And communication is huge. And I'm telling you something you all know, and it came out when you were talking this morning. Why is it that, health social care professionals have such difficulty in talking not only with each other, but also coherently with families, friends, caregivers, other agencies, etc.? What is it that makes it so difficult? Well, communication. Language is the best show that Homo sapiens puts on. At least so it's said. The fact that we can talk, the fact that we can communicate complex ideas, etc., that isn't given to any other species on the planet, although there are other signing systems within other animals. But communication is threaded through role clarification, conflict resolution, collaborative leadership, team function. You can see that, right? It's as clear as the nose on our face. And yet, what trips these things up is an inability to communicate clearly and well. So the goal of a competency curriculum, interprofessional collaboration, when it comes to here, to a practice agency, is really, really, really important to understand and build the curriculum around. Build it so that these things, every student who comes through here goes out of here knowing, that, wow, we learned that there was a little conflict and there are ways of getting around it and doing it. We learned that, collaborative leadership is more than me saying, well, I'm an X and you're a Y, so blah, 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 and then etc. The goal for an agency is to put this into practice. And believe me, I have absolutely no faith in this ever being done in a university hall of learning, ever. I tried it. It doesn't work. It doesn't work because until students actually see, and you will remember this, remember until you actually see a problem that you don't have an answer to, and you have to go to somebody else who's a different health professional, and you say, oh, there's more to this than meets the eye or ear or whatever, So this competency curriculum is right here in this agency. Now, I tell you, so I love these. Here's what I got out of looking at your website. I think this is the website. This is not from the objectives of the IP structure clinical placement. Brilliant. Brilliant. Well done, you guys, or whoever put it in there. Develop and increase. Now, as I read these, think about that definition, okay? Develop an increased understanding of the expertise that each discipline brings to the solution of the health problems. With, from, and about. Learn and develop clinical practice expertise together. With, from, and about. Develop an understanding of team dynamics, etc. Collaboration, 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 right? This is, I haven't seen, I'm not just saying because I'm here, I haven't seen any other agency, I've been to lots of agencies as you know, that's put it this way where I can actually see the definition. We could go through there and you could say, now we're going to do this bit, we're going to do this bit, and we're going to measure it, and we're going to make sure that, et cetera, et cetera, et cetera. I think the preposition is actually beautiful. Yeah, it's on this particular web page. Now, the big problem, I think, with putting the curriculum in place is that there are really some very important verbs that students have to learn as they go through here. But let me back up before I get to this, because this is a little bit longer, and tell you a little story about a visit I had many years ago to our Deputy Minister of Health. Wonderful person, Penny Ballum. She was the bane of every minister and every health professional in the province. She'd been a hematologist. She was the gold medal winner at McGill and did not suffer fools gladly. But she'd been on a committee of mine for a long time, so I knew this woman. So I went to see her and said, you know, Penny, I think we should really be doing something more about interprofessional education for collaborative practice. She said, John, you know what? We don't do that education stuff. We're a service agency. Get it in your thick head. Don't come asking me to do that. We do service. I said, oh. And I feel a little chagrined, but I went away and I had an idea. And the idea was in two parts. The first was I was speaking the wrong language. So you can get back to communication. I was speaking, because I said a couple of words to her that she probably had no idea about whatsoever. And then I thought, but that's stupid. Of course you were doing education, because we have hundreds of students going through the Vancouver General Hospital and the agencies every year. And I know that you're sending your staff off on courses and you put on courses, et cetera. You can't see her. So I did a little back of the envelope calculation just for the Vancouver General Hospital about what the cost was. So I went back to see her. I said, hey, Penny, you know that access problem you have? She said, yeah. And I said, well, I think we have a way of trying to address the access problem. On the waitlist problem? I'd learned that it wasn't any point in saying interprofessional education because that was not the language of that community. So when we talk about doing this, it has to be the language of your community that kind of pulls in those ideas. But the other was, I said, you spend 31% of your budget on education every year. She said, no, I don't. I said, yes, you do. She said, no, I don't. I said, I'll show you how you do it. Okay? So having that sense, having that data sense is really, really important, to go back to the point I made a little earlier. Knowing, what the costs are that are involved and why it is that those costs have to be rolled across interprofessional education for person-centered collaborative practice and care. You don't have to get new dollars to do this. You have to think about the dollars you have and the way in which you will reassign them to what it is you're doing. So let me just get to the verbs. We're almost there. I don't remember when I ran the School of Audiology and Speech Sciences and Rehab Sciences at UBC, I don't remember us ever talking to the students about networking. Ever. I mean, it wasn't in any course that we had in any of those programs. And yet, one of the really, really powerful kind of forces in interprofessional education is the ability to network. To go and talk to other people, right? We spend very little time, if any at all, talking about how to communicate and problem solve clearly, and that is what happens here. That's what you were talking about in the 4 cases or 4 stories, right? And that has to be in this curriculum that you're giving your students as they come here. Managing confidentiality. We did talk about this, and I'm sure you talk about it. And there's a lot of deliberation about, what should and shouldn't be confidential. There's a big debate going on at the present time. But I remember we talked to some kids. Rehab was in the tall building with an elevator. I remember getting in the elevator, and there they were talking about Mr. X. And I said, do you remember what we just talked about? You don't talk about the patients in the elevator. So managing confidentiality, we have to think, that is a really, really important part of the curriculum that we would want to put in here. Cooperating reflectively, and by that I mean, we talk about reflection in and reflection on practice, but I don't think we do a good job of how we use that reflection to aid our cooperation. So we have to think in a new way about how we put that into a clinical curriculum. Negotiating honestly. Yeah, I mean, that's always going to be a very difficult topic. And again, it's like, giving bad news. How do we teach negotiating honestly? And maybe it has to be in the context of giving bad news. But again, it's a verb, negotiate. It's a verb we have to teach. Resolving conflict, we have to teach it. And then the thing that we really, really don't spend any time on is telling our students, at the end of the day, plan realistically. So that's what's so great about what you're doing today. Plan realistically and then follow through. So I don't know how many of these events you've been at where people have these tremendous ideas and go away at the end of the day and say, yay, carrot, and there's no follow through. Now, I'm sure it doesn't happen here, but let me tell you, there are places where people get all excited and there's no follow. And we have to teach students that when they're in these settings, they have to say, well, what's going to happen next? And I don't mean tomorrow, although quite often I do mean tomorrow, but 5 years down the pike, what is the difference going to be from doing it this way? And here's one of your own students quoted on your website, which I think is brilliant. So think of the definition. Having learned about what other disciplines do. With, from, about. With clients inspired me, so see the feedback, to create new interventions. And then the client a more comprehensive experience. Quality of care. I mean, there are you have a number of very nice quotations on the website, but this one I thought, wow, if I wanted to put this up as the poster child for really addressing the definition, that would be it. Because at the end of the day, your service function is enormous. I mean, and I'm full of admiration for what you do here, and I have been for a very long time, and I will continue to be. But the big part that doesn't often get as much attention as it should get is your teaching function. How it is that you are engaged with the next generation of learners, the next generation of practitioners, because it's so, so important. I mean, if we really want to change the world, we've got to send students out there who want to change the world. In my keynote in Auckland, I ended with a quotation from Leonardo da Vinci. And the quotation is, I saw an angel in the stone, and I carved to let him free. We have to have that vision, to say, yeah, we're going to put out practitioners who are way ahead of somewhere else in Toronto that I won't mention. So let me just say a few words about practice education. Aristotle said, for the things we have to learn before we can do them, we learn by doing them. That's what happens here. And this is what I can't get into the thick heads of some of my academic friends. This is where it happens, in practice. And it's true, if you want to do it, you've got to learn. So why did we ever come up with competencies as a method of learning? Well, because we said, in order to do it, we got to do it. And some of you will remember when we used to admit people to health education programs because they were top of the class, only to discover that being top of the class didn't necessarily make them any good at being a practitioner. So let me just make clear that when we talk about facilitators for interprofessional education, we're not talking about preceptors, the people who actually are there to teach the individual how to be the professional, right? So facilitating, those of you who have ever done any problem-based learning will be familiar with facilitating. But facilitators are really, 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 really important. And a mentor's not a facilitator, okay? Mentors are very special people, and I'm sure maybe all of you are mentors in some way to people who come through your facility. But a successful facilitator is somebody who understands the of interprofessional. Okay? Able to walk through what you've been listening to this morning and then communicate it clearly as something that is indeed woven through the training of health human service professionals. So one of the things that we're spending one of the persons we're spending a lot of time thinking about now, working around, is that facilitator. You know, how do we train the facilitator? Because you don't want facilitators who just spout the answer. Right? That was the mistake we made with problem-based learning. We'd ask the biochemists to be facilitators in PBL, and they'd sit there and they'd give a lecture, and we'd say, no, we don't want a lecture from you. You know, we want you to draw out from the students their understanding. And the same is true for interprofessional education, and we've done a lot of work around case-based learning, because it looks like case-based is probably the best way to go about this. So there are these perennial questions that I'm sure you will be faced with. Who and how is a facilitator recruited? Who appoints them? What kind of appointment recognizes a facilitator? How is a facilitator evaluated and rewarded? Very, very, very important. You know, because every time you ask somebody to do something new, rolling across their eyeballs from right to left or left to right is, what's in it for me? You know, so we have to be clear, and we have mechanisms to do that. And then, most important, if in an agency like this, who is going to provide the facilitator development? How are we going to put that in place? And I know there's some of this already, but just to mention it. And to think about, you know, what is the kinds of knowledge that we expect these facilitators. They have to know about competency, they have to know about scopes of practice, they have to know about the patient population, the setting, and they have to know their role and other roles. This is a big piece for them, and they get loaded with a lot of responsibility, right? So when we look at practice educators, just those people who are now working individually with your students from the various programs, we expect them to be a facilitator, we expect them to be a communicator, we expect them to be an assessor, we expect them to be an evaluator, and, you know, if we're lucky, they walk on water. But we do ask these people who come in to do practice education to do a lot of things, to draw on a lot of information. I was delighted to see these two pieces of material. Read, mark, inwardly digest as many times as you can. My colleagues at the University of Toronto have done a fabulous job on these materials. We use them all the way around the world. And let's remember this eternal verity, you know. Cake making must come before cake distribution. And it's great to be here and to know that you have in fact made this huge commitment to sustain. Sustain, sustain, the big S word for all of us. Thank you for your attention, all my relations.
Wow. So first, so we do have a few minutes before we're heading off to lunch, so John will take a few questions. But I just wanted to, just to sum up a little bit of what we heard and what most resonated with me. So we heard a lot about interprofessional practice as a process. And we talked about this morning about communication. We talked a lot about communication, and John certainly emphasized that communication and also decision making. And I think that notion of shared decision making is something that I think we need to think about how we do that more and differently. I think Dr. Gilbert really maybe challenged me to expand the perspective on interprofessional practice curricula, thinking that we actually have a role not only with our students, and we do have a big role to play with students who come through the organization, but with each other. We have a lot of practitioners, some with many, many years of experience, some with fewer years of experience, and we're all learning. We're all learning to be better interprofessional practitioners, whether we're teaching a second-year student or whether we're working and collaborating with someone who's got 20 years of experience in a clinical area. So we're all learners, and I think that idea of our curriculum having to reflect our culture of practice here is important as we think about how we move forward, how we create an environment that we can, hopefully, in a planful way, in a realistic way, measure our impact on collaborative practice. So we do have a few minutes, so I will see, does anyone have any questions for Dr. Gilbert?
One of the challenges in teams that often is not stated is issues of hierarchy and power and issues of psychological safety. So could you just address that as it relates to what you've presented?
Yeah. Well, statement number one, there's a huge amount of stuff on teams. Statement number two, I go bananas when somebody shows me a slide of a team and either a football is being thrown from somebody to somebody or a hockey puck is being pushed from somebody to somebody, and I go, so that's the patient? So it's a very interesting and very complex question. I mean, when you think of a standard playing team, those kinds of issues are there, but they're writ very small. When we are looking at a healthcare team, I like to think of it more as a collaborative, because I think team has, for me now, some effects that don't look at the fact that those people who are working around an individual who has a problem are in fact working collaboratively and not in this team-based way. Now, the issues around power, of course, are known to all of us. So what we try to do is to ensure that the discourse within a setting that is about a patient involves the patient. So today, I apologize, I have not said anything about the patient voice. I said almost nothing about shared decision making, because I usually talk about that with respect to patient voice. But what we're hearing, and it comes to this business, what we're hearing from our patient network, and you have one here, we have a very good one, is that they don't want to be in the center, they want to be in the circle. And that changes the power differential, because even the person whose name we will not mention right at this moment, who has more power than anybody, listens to that person, right? So it's interesting, because we've done some of this, interesting to see how the conversation really changes. Now, I think that, so that's the first. The second is that it depends on how those people in that group are talking with each other and not at each other. So we've all been in those settings where people were talking at each other and they're not really listening, right? So talking with each other really requires a different way of talking, you know? And no longer, and you only have to look at things that escalate up the conflict tree to realize that this talking is always at, it's always at, and then it's at, and oh, by the way, I have the power differential. So I think that once we bring and it's always lovely to hear about children, because in this setting, that conversation always has to have that discussion, right? It's inevitable here. In acute care, it's very different. So I think we won't ever get over that kind of power thing. I had lunch with an old mentee of mine on Saturday who's a pathologist. She's a wonderful pathologist. And we were talking about nurse practitioners, because nurse practitioners can do what 82% of a general practitioner can do. And her brother, who's a big shop lawyer in New York, was at the table, and he's saying, well, you know, why don't you just, you know, pay them the same amount of money, et cetera. And then his sister says, wait a minute, you know, they went to medical school, and, you know, nurse practitioners didn't go to medical school. And so then you have to have this discussion. It's not about them, it's about the patient. You know, take your mind off you and put your mind on the person you're trying to serve. It's a very difficult, and in industry, it's a huge issue. That team-based thing in industry, you just have to look at all of the stuff around gender-based, you know, conflict, huge issue. So thank you. Yeah.
question for Salma and Jeff?
Yep, I can probably hear you. I can hear you. Oh, they want to record it.
So I just wanted to comment on not just power, but I'm just thinking about being valued as a team member. I think there's a lot of, we're really fortunate here. We work with really great people. But I think there's a sense of not a power struggle, but a sense of one profession's more valued than another, and whether it's by token of opportunities to participate in things or salary levels or whatever it is, those different types of things that sort of make us feel a little bit less valued than some other profession. And I think maybe that's where some of that power, because I don't ever feel that I'm powerless, but I do sometimes feel undervalued. So I just wanted to make that clarification. And I don't know if you've seen that in other places.
Well, in the health and human services sector, StatsCan has, I think, 68 occupations that it follows. In the United States, it's something like 255 or something like that. But within our own settings, one of the problems is that some of those people are hidden, right? So you think of a lab tech, for example. Lab techs are hidden. Think of those poor pharmacists. Where was the pharmacist? They were always hidden in the basement, right? I mean, that is an issue. So, and the person who cleans the rooms. I remember being in hospital in Vancouver. Well, actually, it was in Richmond. And into my room came this man with the broom and the brush and all the rest, and he said, "Now, Dr. Gilbert, I want you to know I am the most important person on your healthcare team." I said, "Yes." He said, "Yes, because I'm going to prevent MSRA from getting you today." And he's hidden, right? So he's hidden. So organizations, I think, have a responsibility to recognize, whoever's the CEO and sits at the table up there, to recognize that the hidden people have to be shown that they're as important to the organization, because otherwise it would fall down. And I think there are ways of doing it. I've seen it in some of the smaller hospitals in BC, which is very nice. But yeah, the hiddens. But we actually brought the pharmacists out from behind the counter, and they now talk to the patients, and they give injections and all that good stuff. But I don't know about my room cleaner. I mean, he was just a great guy. But yeah, it's a big issue, and the recognition is important, as is recognition, for all the work that we do. You do every day. So, yep, okay, good. I don't want to keep them from their lunch. Thank you all very much.